Good afternoon, everybody. I'm Ellen McKenzie, Dean of the School of Public Health, and I'm just so glad that you're all here, either in person, and we do have people online. It doesn't look like it, but we do have people online. And so welcome to those who are able to join us online. And welcome to the first Dean's Lecture of the academic year. As you know, this series is it's a great opportunity for us to showcase the work of our newly appointed and promoted professors and senior scientists. It's a chance to hear firsthand how our colleagues are changing the world through the power of public health. And today, I am really thrilled to welcome Caitlin Kennedy. As many of you know, Caitlin is an accomplished social and behavioral scientist with a focus on HIV prevention. But here's a fun fact that you may not know about Caitlin, and that is she speaks Ewe, a language used by about, 5 million people in West Africa. And she first learned Ewe when she joined the Peace Corps and was assigned to Togo. During those 2 years, she was a community health and AIDS prevention volunteer, an experience that left her with a desire to gain more training and skills. And very fortunate for us, that desire led her to the Bloomberg School of Public Health. She earned her MPH here and then her PhD. She couldn't get enough. She went right on to the PhD and was a member of the prestigious Sommer Scholars Program. When we select Sommer Scholars, we are looking for students with exceptional leadership potential, and Caitlin has certainly delivered. She joined the faculty of our International Health Department in 2009, and ever since, she has been steadily building a career right here at the School of Public Health. Her work is helping to promote better sexual and reproductive health in resource-limited settings, and she is committed to translating research into effective programs and policies that really make a difference. Caitlin has advanced our understanding of the complexities of HIV risk and contributed to the development of tailored services for highly vulnerable groups such as sex workers. Among her many, many accomplishments, she has conducted vital systematic reviews of behavior change studies and made substantial contributions to crafting WHO guidelines. She's also deeply involved in the school's research in Rakai, a rural district in Uganda, that has one of the longest running cohort studies on HIV. There's an incredible history as well as a future to this work, and I look forward to hearing more from Caitlin about this today. Now, beyond all the research that she does, Caitlin shines as a teacher, a mentor, and a faculty leader. She serves as program director for the Social and Behavioral Interventions Program, known as SBI, in the Department of International Health. And in this role, she provides vital advising and support to our SBI students and mentorship to SBI faculty, including the many SBI faculty in the Center for Indigenous Health. But she's also the faculty leader of our Sommer Scholars Program, which is a lovely full circle moment as Caitlin was an alum of that program and one of the very first, as I recall, the first, or among the first. Sommer Scholars. So it's just wonderful to have her as the director of the program, and she does a marvelous job. She has won many Golden Apple Awards for her teaching, as well as the Faculty Mentoring Award. She's known for being down-to-earth, flexible, and kind, and is admired for the many ways she looks out for the people all around her. In fact, when COVID-19 kept us from being indoors, Caitlin would often invite people to gather in her yard outside. Properly distanced, I'm sure. I know we all remember how hard it was to be apart those days and how much it meant to have those moments of connection, and Caitlin surely provided those. Her generosity in welcoming people to her home is indicative of the warmth and openness that Caitlin brings to all that she does. I should add that she still loves inviting people over, whether it's for a training session, a writing retreat, or just a party. I'm told that she sometimes has over 100 people in her house at a time, and that her dad will show up to play the accordion. So I've never received an invitation to one of those parties. I would love to hear your dad play the accordion one of these days. But Caitlin, Professor Kennedy, thank you for all you do for our school and obviously for the field. Your work gives us hope for the future of HIV prevention and care, and your passion and commitment lift up everyone around you. So I'm so glad to have a chance to hear from you today. So please come on up.
Thank you. That was lovely. And I'm pretty sure my dad would be happy to play the accordion for anyone here who would like to hear it, right? Oh, he says for money. All right. Well, welcome, everyone. I'm going to talk with you today about some of the work that I do, from local stories to global evidence, improving HIV outcomes in Uganda and beyond. All right, so I'm going to talk in 3 parts. The first part is going to be about local stories, speaking about some of the qualitative research we do with a focus on Rakai, Uganda, as Ellen started to introduce. Then I'm going to move to global evidence, talking about WHO policymaking and how we've worked on that. Then I'll make connections between those two, and I hope that this talk will make a lot of different connections. Part of putting the story together of your work and your career is thinking through, well, what are the connections? What is the storyline here? How does this all tie together? And so I hope to not only talk about the connections between the local stories and the global evidence, but throughout in what I've chosen to highlight, I'm trying to highlight other connections, like through the qualitative work we do and the quantitative work we do, and connections across projects and across people, because I really think all of it today that I'm going to present is a collective effort, and all of these connections are critical to making the work happen. And I'm going to say we a lot today in our presentation, because none of the work that I'm presenting today is mine alone. It is always part of large groups of people, and in fact, very often I am just hiding in the back of the middle, not even leading this work, but I'm presenting what other people have done and the collaborations that I've been fortunate to be a part of. So we'll start with local stories. And Ellen mentioned that I was a Peace Corps volunteer in Togo, and the other person who speaks Ewe in this school is Agbesia Muzu, who is from Togo originally. So he can keep me honest about how well I actually speak Ewe anymore. But I am actually not going to start from when I was a Peace Corps volunteer in Togo. I'm going to start in Uganda. And many of you in the room, I'm sure, know Uganda and have been there and are very familiar with it. It's a landlocked country in East Africa. And I'm going to talk about Rakai down here in the south central part, bordering Lake Victoria, the largest freshwater lake in Africa, and the Tanzania border. And so Rakai is well known to many people in this building. Why rural Rakai? Well, it was an HIV epicenter. So Rakai is the location where the first cases of HIV were identified in Uganda back in the 1980s by this group of individuals, David Serwata and Nelson Sowankambo, who were young doctors at the time, went out looking for HIV and found it in Kasansero in the Rakai region. And following that initial report in the Lancet in October 1985 of what they were calling slim disease, a new disease in Uganda, they really built up a whole body of work, I was going to say empire, it's not an empire, a whole impressive group of people working in HIV over many years and contributing a lot to not only the knowledge in Uganda, but also globally. And that collective set of enterprises that have developed over the years have really been grounded often in collaborations with this school through some of the faculty who started working with Nelson and David, Ron Gray and Marie Waver, who they contacted to say, hey, maybe we should do a small study to actually see what the prevalence of this, now that we've identified this disease, what's going on in Uganda. And that grew into this enterprise that now has had decades of collaboration between Johns Hopkins and colleagues in Uganda. And I benefited from that as an MPH student when I first came here. I remember sitting in this room when it was East Wing Auditorium and listening to biostats lectures where they would use data from the Rakai Community Cohort Study, and we would use that for our exercises. And in those classes with me were Joseph Kagai and Nema Nekyanjo, who Joseph was doing his MPH at the same time as me. He went on to become the executive director of the Rakai Health Sciences program, and Nema Nekyanjo took the qualitative research course series with me here as an MPH student, and she's now the director of the social and behavioral sciences division at Rakai. So these connections really have built up over many years. So those group of individuals from that original seed of finding those first cases of HIV in Uganda, they built up the Rakai Health Sciences Program, which is an NGO located in Rakai that has all kinds of work. So they're well known for the original male circumcision trials that showed that male circumcision helps prevent HIV, for one of the 3 original trials. They've been doing, as Ellen mentioned, the longitudinal Rakai community cohort study for several decades now, where they have been collecting data for about 20,000 individuals every year, year and a half over time, and following them to understand a range of different topics related to HIV. They also do clinical work, so they have been a PEPFAR program implementer and providing clinical HIV services to large numbers of people in the area. And they also have a qualitative research group. So they have a social and behavioral sciences department, which is where most of my collaborations have happened with Rakai over the last 15 years or so. And here is a good number of the qualitative research team in Rakai. So that's me in the bottom and Nema in the blue shirt above me, and several of the interviewers, the ethnographers, and also some Johns Hopkins students and faculty with us. So with this group over the years, we've done quite a number of different qualitative research studies. And I've just chosen 3 to highlight here. I think some of the people online might be students in my current qualitative research course. So if you're listening in, I've chosen purposefully some different studies that highlight different aspects or ways that you can do qualitative research, and also different links between qualitative research and other study designs like quantitative research. So the first one I'm going to highlight is talking about ART drug diversion, which uses a mixed methods approach. Then we'll look at cognitive interviewing through our study of psychological distress. And then we'll look at narrative timelines through a study of HIV treatment trajectories. So we'll start with some research that we did on ART drug diversion. So this project came out of conversations through different co-investigators who were working with Rakai data. And I was listening in to the part about HIV drug resistance. And people were talking about the HIV drug resistance data that they'd been getting and some of the patterns that they were seeing that didn't quite make sense based on the regimens that were on offer. And ART is antiretroviral treatment for those who aren't familiar. And so they were saying, well, what could this be? Could this be that people are like mixing their medications with each other, or are they sharing? And Caitlin and Nema and others, could you maybe do some qualitative research to see if anybody's sharing their medication? Like, what's going on here? Why are we seeing these drug resistance data? And drug diversion or HIV medication sharing is not something that had ever really been looked at in HIV before this time. We all know drug diversion is common for other diseases and illnesses, and you all may in your bathroom medicine cabinets have some old antibiotics that someone prescribed you that you may be willing to share with someone else in your family later on for something that was not the original prescription. And so drug diversion is this transfer of prescribed medication from the individual to whom it was prescribed to a different individual. And this can include buying, selling, borrowing, or lending medication. And so we said, all right, well, let's go and talk to people and see if any of this is maybe happening. So we conducted a qualitative exploration in fishing communities in Uganda. So why fishing communities? Well, those of you who are familiar with Uganda may know that fishing communities have a really high HIV burden. This graph here shows data from the Rakai community cohort study, and the fishing communities are all in blue compared to agrarian or trading communities. And as you can see, the HIV prevalence in those communities is extremely high. It's between 30-something and 40-something% across communities and across years. So basically a third to almost half of the adults in those communities are living with HIV. And that creates a really unique set of social circumstances and situations that are not necessarily present in the more rural inland communities, the agrarian communities, or the trading centers, the towns where people buy and sell goods. And so over the years, we've looked at various different social dynamics around HIV in those fishing communities because they're so important. And so we decided to start with these fishing communities around HIV medication sharing. So we did a study. We interviewed a number of HIV positive fishermen and HIV positive female sex workers. And they told us, yes, actually, we share our medication regularly. This is pretty common. They said that when they run out of medication, they will share with their colleagues. They know lots of people who are also HIV positive, and this was pretty common. And they frequently have challenges getting back to the clinic to get their medication, or they are migrants, and so they move from place to place and can't get their medication. And so they were saying that, yes, this is really common, and we do it pretty regularly, and it's really a form of adherence. This is a strategy for us not to, they said, buying, that doesn't really happen, selling, that doesn't really happen, but it is really, we share with each other. And Uganda has a very collective and communal culture where sharing what you have is often expected and normal. And so we said, okay, well, this is really interesting. We found that this seems to be happening, at least among the people that we spoke with. But of course, this relatively small qualitative study was designed to explore what was going on with this situation, but wasn't designed to assess how common is it, what's the prevalence, what factors are associated with sharing, et cetera. So the benefit of working with RCI is these long collaborations. So we were able to incorporate some questions about HIV medication sharing into the RCI community cohort study. So this picture is the tents that are set up by the RCI community cohort study. They go out into these different communities. There's 41 communities in rural Uganda. And for each one, they go in, they set up tents. They invite all adult individuals in that community to participate in the study. And again, year after year, people participate in many years. And these tents are where they do the HIV testing, where they do the informed consent process, and where they do the interviews. So we added questions so that we could get a population-based sample to assess how frequent is HIV medication sharing and what are the factors associated with this. And we were able to interview almost 3,000 people living with HIV who were self-reporting that, yes, they were currently on ART, more women than men. And overall, 9.3% said yes, they had shared their HIV medication in their lifetime, and 6.8% reported ART diversion in the last year. So this was helpful to know how common this was. And we found, as we had seen in the preliminary qualitative data, that giving and receiving drugs were the most common. Very few participants reported buying, and no one reported selling. And so we did some quantitative work where we saw, looking at that men were more likely to report lifetime diversion than women. And when we did stratifications by gender and age, we found that men aged 25 to 34 reported ART sharing most frequently. So 18.9%, almost 20% of men said that they had shared their HIV medication. We also looked at things like the source or recipient of shared drugs in the past 12 months. And we found that by far, friends were most commonly reported as people who had shared drugs, followed by spouses or sexual partners. And this was a little surprising to us. We had assumed that because spouses are often both living with HIV and they live in the same household, that they might be more likely to be the source or recipient of shared drugs, but actually it was friends. And this really aligned with our qualitative work among fishermen and sex workers who said their colleagues and friends that they worked with or knew through those networks were the ones that they shared with. And then finally, we looked at associations. So we found that compared to people who did not report any ART diversion, people who reported only giving ART to others were twice as likely to be viremic, meaning they're not virally suppressed, compared to those who reported no diversion. And those who reported only receiving ART were less likely to be viremic, although this difference was not statistically significant. And then reporting both giving and receiving was not associated with viremia. So this was really interesting. We got this quantitative data, but then yet again, we had more questions. So we said, okay, why are we seeing these associations with viremia? We need to do more questions. And now that we know that this is fairly common, what should we do about it? We need to talk with clinicians. This is not anywhere in the Ugandan national HIV guidelines to talk about this. What should we be thinking about as we move forward? So, of course, that leads to more research. And those of you who've taken mixed methods classes know that could see this potentially as a form of an explanatory sequential mixed methods design, where you start with some qualitative data that gives you some informs then the quantitative data that you have, and then you interpret that. But really, what I hope this story shares is something much broader than that, which is a real-world research process where we got the idea for even doing the qualitative work from this drug resistance data. And then that quantitative work has now led us to more questions, such as more qualitative data collection that we're doing now, which is how do we address this in interventions? How do clinicians talk with clients about this? Should they? What should they be saying, if anything? And more quantitative data collection. So we have cross-sectional data from one round of the RCCS, which is great, but now we want to look longitudinally. Does this actually predict things? Are there associations with things like drug resistance that we need to be looking at? So this real-world complexity of how qualitative and quantitative data fit together. And on and on. All right, so that's one study, one local story of what's going on in one part of Uganda, of Rakai. The next study that I'm going to talk about is looking at psychological distress among people living with HIV. So this was work led by really Nora West, one of my doctoral students, where we did in-depth interviews with people living with HIV, and we're looking, and as well as health workers and key informants, where we were really looking at ideas around how people expressed idioms of distress or how they express psychological distress. And this was built off of work that maybe even some people on this call have participated in from years ago in Rakai, where they found that there were local idioms of distress that didn't necessarily align well with our Western categories of mental health that we use to measure things. And we wanted to re-explore this. And what we found were a few different local terms or idioms of distress of how people described psychological distress that didn't rise to the level of a mental disorder, but was still important and something to consider. So the first was a term for worry or apprehension, and the second was a term for being in deep thoughts, in many thoughts. And both of these were described as sort of being on a continuum before mental disorders. And for both of these, we then looked at in more detail at what drove those different local conceptions of illness, the signs of those, how someone would notice when someone was in worry, apprehension, or in deep thoughts, and how does that impact their HIV treatment trajectory. So does that impact their adherence or their functioning, their ability to focus on work, et cetera. And we did this qualitative work. We found these local idioms. They actually aligned, and it was very helpful to look back 20 years on what was similar and what was different. And there were a lot more, I will say, Western and English terms for mental health disorders that had filtered into the language, particularly of providers, although not necessarily the language of some of the clients that we were working with. And so from this work, we said, okay, great. Now, the whole purpose of doing this qualitative study was to inform the quantitative data that we're collecting as part of the RCCS and to tell us how we better measure these things. And we realized that especially this idea of being in deep thoughts or many thoughts has been seen across studies. So there are people here again in the mental health department who've done some work on this, who found that across settings, this idea of being deep in thoughts is a common idiom of distress. And so we decided to do some cognitive interviewing with a few different survey measures. And so cognitive interviewing is another way to use qualitative research methods, different approach, where you use qualitative research to understand how people interpret survey questions and what they're thinking about as they answer those survey questions. So we took 3 survey measures that are common for symptoms of psychological distress. This thinking too much questionnaire, which was developed by people using this cross-cultural data. We took the PHQ-9 or the Patient Health Questionnaire 9, very commonly used measure, and the Hopkins symptom checklist. And so each of these has a long, list of questions like in the last 2 weeks, how often have you felt little interest or pleasure in doing things, feeling down, depressed, or hopeless? Those of you familiar with the PHQ-9 will recognize these as measures from the PHQ-9. And what we did is we asked people, so how do you respond to this question? And then tell me how you came up with your answer, right? Can you repeat the question I asked in your own words? Or how easy or hard was this question to answer and why? Or how do you interpret a certain word within this question? So that we could get at their thought process of how they heard the question, what they thought about in terms of choosing then the answer that they gave. And so this was really helpful because we found that for several of the items, like this item on the PHQ-9, which is trouble concentrating on things, such as reading the newspaper or watching television, that people, when they described what they thought about when they answered that question, they really focused on the second part of that question, which was the television and the radio. And they said things like, well, I don't have a television, and so I don't really watch television that much, so I answered it this way, right? Whereas if you look at this question, the goal of this question is really on that concentrating part, right? The trouble concentrating. And people had kind of forgotten that first part by the time they answered the question. And so we reworked this survey item where we dropped some of the details about examples. and still had to really work through to think about, well, what's the translation and the word that we're going to use for concentrating? Because that key idea that seems so obvious to us in English was we were having trouble thinking about how that came across in Uganda. So again, another way of thinking about these connections between qualitative and quantitative work, the work that we did here then informed some guidelines about how we might think about translating and using which of these measures and which ones might be more accurately capturing what we're hoping to capture. And for those of you who do mental health work, you may have seen there are several other studies that have also found that the PHQ-9 doesn't really work that well in Uganda, even though it's used everywhere and is in the HIV guidelines. All right, so the third example I'm going to talk about is a study on HIV treatment trajectories. Again, one of my doctoral students, Greg Rosen, really led a lot of this work. And our goal with this study was to look at treatment trajectories for people living with HIV who were not virally suppressed. And the reason for this is that, HIV epidemiology is changing over time. Globally, we have done an amazing job as a collective global force in shaping the trajectory of HIV and in getting treatment to people and in getting services to people and getting prevention programs out there in the world. And that's changing who gets HIV, and it's changing why people might not be virally suppressed. So who we're missing is changing over time. So we did some qualitative interviews here where we focused on a timeline approach. And our analysis approach was focusing on restoring these timelines along with a traditional thematic analysis. Those of you who do qualitative research may know that we often do thematic analysis. We're looking for the themes or the similarities of what people say across interviews, but that doesn't always give us that longitudinal story of what leads to what, or how things fit together in a process. So we did these interviews. For each interview, we then created a timeline, and this is an example from one participant, where we went back to the stories that they were telling us and pulled out the important turning points or trajectories or moments that seem to shape their experience with HIV medication the most. And so this is an example from someone who started with developing symptoms, had an early HIV test at a clinic and tested positive, but was scared and didn't believe that result. And then again, we highlighted different events along that person's trajectory. And this is another example of a timeline that we created, where again, we were working, this person had a more complex story to tell, more events, but we were looking at what was that pattern of events that we were seeing over time. And what we did with each of these timelines, so for all the participants, we built out a timeline, and then we looked across the timelines to see, okay, are there patterns and similarities in some of these pathways that people have, and reasons why they might not be suppressed. And so we started to consolidate the timelines into different trajectories. And so this is an example trajectory of someone, these are all pseudonyms, who we named Nelson, where this trajectory was defined by delayed ART initiation. So not starting their HIV medication right away, often because people didn't really believe their initial diagnosis or had other barriers to starting ART. And so we created then these sort of consolidated timelines across people and ultimately identified 6 different categories or different stories or trajectories of why people were not virally suppressed. So you can see here, Nelson at the top, A is delayed ART initiation, whereas Agnes, the second trajectory that we identified, was early discontinuation. They started ART right away, but then discontinued. And again, we found patterns of people who did treatment cycling or who had prolonged treatment interruption or transfer-related care disruption. So again, different reasons why and different stories for how things fit together. And ultimately, the goal of developing these trajectories is to think about, well, not everyone needs the same interventions. And we just look thematically, we might miss the patterns that people are experiencing over time. And the goal of this was to, again, inform clinical services about reaching out to these people who are not virally suppressed to see what we can do to actually engage them in care. And as you can already see from these timelines, there's different strategies that are going to work for different people. So those are my 3 stories, 3 examples of qualitative research we've done over time. And I have to say, even picking those 3 stories was hard, because one of the benefits of qualitative research is we can just use it to answer so many different questions. And there are always these questions that come up that we would like to just talk to people about and figure out what's going on and what do they say about this, right? And so over time, we've asked a lot of different questions. As the HIV epidemic has changed, as new interventions come out, we've asked, that says, how do you feel about your husband getting circumcised to prevent HIV? We've asked questions about PrEP rollout and peer health worker programs, what's working with those programs, what's not working, what they might hypothetically be interested in doing in the future, and then what are some of the social dynamics around what's happening. So that's the end of my local stories component. And obviously qualitative research is more than just stories, but they start with stories, right? It's fundamentally about listening to people and hearing what they have to say. So now I'm going to switch to talking a little bit about global evidence. In my classes, I always suggest a stretch break if you need one. The other thing I could have titled this part was why I think systematic reviews are exciting. So hopefully by the end of the next 10 minutes, I will convince you also that systematic reviews are very exciting, even if right now you're saying they are deadly boring. So when I was an MPH student, so I came here as an MPH student, I was looking for a work-study job, was interested in global HIV, and this person right here in the yellow shirt, Mike Sweat, was my advisor, and he was offering some work-study positions, doing systematic reviews of HIV behavioral interventions globally. And I thought, okay, well, this is why I came to Hopkins, to work on global HIV. This is very exciting, and the systematic review part sounds a little boring, but okay, I will just do what I need to do. And at least they're paying me to read a lot of interesting articles. So Mike was working with this other man in the blue shirt, Kevin O'Reilly, who was a technical officer at the World Health Organization at the time. And I was part of the team as a master's student. And then as I finished my master's program, I stayed on as a staff member, a research coordinator, to help lead these systematic reviews. And we were just going one by one around different topics for HIV prevention, behavioral interventions for HIV globally. And that was great. It led to a lot of publications, which is always nice for someone junior in their career. And we were sort of working through one by one the evidence for each of these different interventions. And then Kevin O'Reilly was working for WHO, and part of the reason for this collaboration was at this time, WHO had been getting a lot of criticism. So right around the time I started working with them, there was a big article in the New England Journal of Medicine, I think, or maybe it was the Lancet, that basically said WHO just brings together the old boys network, their friends in a room, and whoever shouts the loudest gets their voice written into the WHO guidelines, and they don't use an evidence-based systematic process to make their recommendations. And so WHO said, okay, we need to use an evidence-based systematic approach to make our recommendations because we've gotten this criticism. And so that's how our systematic reviews got incorporated into WHO guidelines. And this was my first WHO guideline that I ended up working on. This was at the time when HIV treatment was being scaled up globally, which was hugely exciting. And WHO basically wanted to tell countries, hey, wait, it's not just giving drugs to people. Please, there's a whole package of other services that may be useful before people need treatment and also after them. So prevention, care, interventions for people living with HIV. It's a whole package. And please don't just give them a pill and think that that's all you need to do. So this was very exciting because our systematic reviews were used as the body of evidence for this first guideline. It was also exciting because I got to go to Switzerland for the first time. This was the view from my hotel room. I was super thrilled and excited to be there and also be in the room where they really did bring together all of these global HIV experts, where I got to listen in, hear what was happening in this policymaking process. And ultimately, they used our reviews. I saw line by line how we had pulled out data from these studies, and that was then used in this global policymaking effort, which was very exciting. So my experience with lit reviews just sort of ballooned from there. And again, I tell students, be careful what you get expertise and training in because you will then be asked to do that because you know how to do it for the rest of your career. So somehow I got expertise in doing systematic reviews and meta-analysis and guidelines and ended up being asked to keep doing it. So my work with WHO, that original guideline, put me in touch with people for the Cochrane collaboration. And they had just been asked by WHO and UNFPA and IPPF, the International Planned Parenthood Federation, to do a systematic review for USAID on linkages between sexual and reproductive health and HIV. And again, at the time, there was recognition that HIV had been largely these vertical programs that were not linked or aligned with other sexual and reproductive health services, even though someone who needs HIV prevention may also need pregnancy prevention, may also need these other services. And so they needed someone to take the lead on this review and actually do the work, which I was positioned to do. So we did this whole review on linkages, and based on our findings, USAID then formed a working group to examine, not just examine, but actually figure out how to incorporate linkages between sexual and reproductive health and HIV into all of their USAID programs. And this was hugely exciting because it was actually program impact, right? Like USAID, for those who know, has millions of dollars. They have all these programs. And if they're asking every program in countries around the world to think about how do you actually integrate these services, again, the systematic reviews that we had done where we talked about here's the evidence for how to link and what works and maybe what doesn't work so well, was showing up in all of our programs, which was very exciting. Then that work with lit reviews led to additional work for systematic reviews with WHO. Over the last 20 years, I think I've worked on about 20 different WHO guidelines. And it's all thanks to this handbook for guideline development that WHO came up with shortly after our very first guideline that we worked on with them. So after that guideline, WHO went full circle and created a whole manual, a guideline for guidelines, about how to use systematically evidence in WHO guidelines and a systematic process that everyone had to follow if they were going to make any recommendation from WHO. And as part of this process where they have to, before any recommendation gets made, they have to do this whole process. They require evidence retrieval, assessment, and synthesis through systematic reviews, and putting that into a very specific framework called the grade process, which is highly detailed and technical. And so basically every time there's a guideline like this is an example WHO guideline. If WHO wants to make a recommendation saying, like HIV post-exposure prophylaxis should be delivered in community settings. You don't have to only deliver it in a clinic or a hospital. You should deliver it elsewhere, or other recommendations. They have to go through a long and painful process of outlining exactly what they're going to study, how they're going to study it, pulling the literature together, looking at all the different evidence, and then putting it into these long and complicated tables. Please don't read this. This is not the point, but the point is there's very highly structured way of doing this and pulling together this epidemiologic evidence and presenting it back to WHO. And there's a whole, again, manual about how you do this and how each one of these cells gets graded and figured out. And lucky me, I was around when it first started so that I figured out how to do this, and now just keep getting asked to do it again and again. And so what we do is we pull together these very detail-oriented tables, pages and pages of these tables that look like this. And then we go in a room like this, or hopefully a little bit more of a circle. This is an example from a WHO meeting, where we then on the screen present those tables and tables of evidence and go through the process that WHO requires for this guideline development group to then make a recommendation. And I've been fortunate now to be part of this process, both as the systematic reviewer and also as the methodologist, making sure that people are actually following the methodology that they are supposed to be following in a room like this. And the people who make WHO guidelines are pulled together very purposefully from different communities, those affected by the health condition or whatever topic is being studied, academics, people from ministries of health, people from NGOs and other sectors, to be sort of purposely representative, listen to that evidence and bring it together to make a recommendation. I will say not all WHO meetings are in ballrooms quite this grand. This was a very grand one as I was looking through my slides. Some of them are just much more cozy around a table, but they all give nice opportunities for me to take a photo of my name tag on a plate, apparently, in front of people. But anyway, this is the process through which WHO makes their recommendations and guidelines. And again, over the years, I've been involved with quite a number of these now. And through all of it, I see those systematic reviews go from taking those studies that have been done, gathering them together, pulling the evidence, and then that evidence is used directly to inform policy. So again, if I say this is why I think systematic reviews are exciting, it's because I've seen them have real impact in both programs and global policy development. And you can, again, see those threads. So there's another reason I think systematic reviews are exciting. Going back to 2006, this is this first WHO guideline development that I was ever involved with. It was very exciting. I showed you that picture from Geneva. And then I also happened to meet someone who was working, who had just finished residency and was working on the clinical side of those guidelines. I was working on the behavioral side. And that was 2006. We were exhausted because I was just young enough in my career that I could like do a lot of the work, but also be asked to do a lot of the work. So I was exhausted. And now in 2024, he's my husband. So I don't know if anyone's looking for a life partner, but may I recommend systematic reviews as a great way of meeting your life partner, and in the front of the audience. So hopefully, if you're not looking for a life partner, hopefully the policy and program Global Impact was also very exciting. All right, so now I've talked a little bit about some of our local stories and the qualitative work that we do in Rakai and elsewhere. I've also talked a little bit about global evidence and this policymaking process and how that evidence gets used in making recommendations. And now I want to talk a little bit about how do these two things fit together at the surface. These two parts of my work are very disparate and seem like they're in totally different places, right? Talking with people near a beach by Lake Victoria, one-on-one about their experience living with HIV, or going to these global guideline meetings. So I see a few different ways in which they're connected. The first one is going back to this WHO guideline development process. So in addition to synthesizing the epidemiologic evidence for any topic, WHO also requires that as you formulate those recommendations, you take into consideration not only whether the intervention works or not, but also how people feel about that intervention. What are the values and preferences that people hold around it? What are the benefits and harms that they see? Resource use, feasibility, acceptability. Will people want to do this? Will they be willing to do it? And I sometimes use examples like, there may be a very effective intervention, right, to prevent the common cold or the flu. But if you knew that you could prevent the flu, but you had to like tattoo a swastika onto your forehead, that would probably go against your values and preferences. And you might choose not to get that intervention, even if it was effective at preventing flu, because it doesn't align with your preferences and values. So as part of this WHO process and knowing this WHO process, we were able to bring this to our work in Rakai and in Uganda. And so several of the qualitative studies we've done, for example, this one was about HIV partner notification. So the history of HIV over the last 20 years has been just new innovation or intervention after new innovation, and new things have been coming out all the time. And often we've been asking people in Rakai, well, how do you feel about these? And what do you think about partner notification? Would you be comfortable if we notified your partners about something? What strategies would be appropriate for different types of partners? And doing that qualitative work, we've been able to then use that to inform WHO guidelines through that process of looking at values and preferences, because often what they're doing is gathering the evidence on values and preferences. So this paper right here was used directly to inform the partner notification guidelines that WHO came out with. We also, another example, we did a paper on self-testing, HIV self-testing, where you test yourself, get your own result, as we all do with COVID now, was a new thing for HIV, and people weren't sure how people were going to feel about that, and it's a pretty big diagnosis. But we did some acceptability work. And again, that was used as part of the values and preference evidence-based for the WHO recommendations on self-testing. And I will say it's one of these situations where I find the connections between the work we do in Rakai and the WHO work to be so helpful in my own positioning, because hearing what WHO is talking about, what they think is important at the global scale, then informs, I sometimes go back to our colleagues in Uganda and say, hey, I think this might actually be really relevant if we did a study on this. I think it could inform some future work, or vice versa, taking what's going on the ground and hearing what WHO is talking about and saying, well, you are doing these whole guidelines on this new topic, but I don't hear anything about this. Is that relevant at all? And those sorts of connections back and forth have been hugely valuable. We've also had other global connections. So our work on antiretroviral therapy sharing that I talked about earlier, a couple of years ago, I was talking with our Foundations of Global Health class, and they asked you to talk a little bit about a current study you're working on. So I said, oh, we're doing this work on antiretroviral drug sharing in Uganda. And this student came up to me afterwards and said, oh, during COVID, I was working in China with UNAIDS, and there was actually antiretroviral drug sharing going on in China too. Only it looked really different because people were online and in these chat forums, and it was being facilitated by people who, in very strict COVID lockdowns, couldn't leave their apartment building. And so these NGOs that knew people living with HIV were helping to facilitate who could share some drugs with people before they could get AART. And I said, oh, well, that's really interesting. Has that been documented anywhere? And she said no. So it led us to do a project that we're working on right now, documenting what happened in China with ART drug sharing. And again, a very different pattern of why people were sharing drugs and how that worked. But again, the local stories from Uganda now informing, this is a former PhD student and a former master's student who's at Peking University now. We collaborated with them to figure out this work. All right, so that's a little bit about local stories, a little bit about global evidence, but then the rest of my title was Improving HIV Outcomes in Uganda and Beyond. And as I was you have to give your title way in advance of when I'm actually doing the slides. So I was putting together my slides and I was like, ooh, that second part of the title, maybe I should have left that off, Improving HIV Outcomes. So I thought, okay, well, what is the story of HIV outcomes in Uganda and beyond? Well, this is data from the Rakhine Community Cohort Study over the years, and there has been tremendous improvement in HIV over the last 20 years. Since 2004, when I got my MPH, really HIV incidence has declined dramatically in Uganda. And there's been a huge increase in service availability, and things that just weren't possible when I was envisioning it are now very much possible. So this is very exciting. And then also globally, this is data from UNAIDS showing again over the last 20 years, when I started getting interested in HIV was when we were on that upswing of the curve, when HIV was just seeming to get worse and worse and worse. And right around 2004, you can see is when HIV medication was coming out and when these services really started to get rolled out with PEPFAR and others. And it's been a huge success in many ways. UNAIDS estimates that 20 million AIDS-related deaths have been averted in that time, which is hugely exciting. But what was my role in that, right? Improving HIV outcomes in Uganda and beyond? Well, I don't think I can claim a single one of these AIDS-averted deaths from the qualitative work we do or the global guidelines. But thinking about it, I've had the privilege to just be involved in so many different projects and in so many different ways. This huge group of people globally and in communities around the world working to address HIV, to address these sexual and reproductive health issues. And hopefully we've all collectively contributed to this, even if I myself cannot claim any one of these. So with that, I wanted to just acknowledge that this is really not about me. This is about these communities and groups that I've had the privilege of working with, starting from being a student here and gaining those connections and relationships with people. I can't tell you how important it is to have trusting relationships with colleagues that you work with, and being in the same MPH class and knowing someone before they got married and knowing who they dated and what they were drinking in that bar that night is really helpful for forming those relationships many years down the line. I want to say we stand on the shoulders of giants, but I had a colleague in Uganda who said, no, we don't. We stand on the shoulders of silverbacks, right? These silverback gorillas. I have not had the privilege of seeing a silverback gorilla, but there are really a lot of giants in the field and mentors for me who I really owe a lot of support and gratitude for all of this work. And here are some of them. I don't have time to name everyone, but some of them are in this room. Thank you so much for coming. It's really been a journey for me across these last 20 years of being at Hopkins, and a wonderful set of people who have mentored and supported me along the way, and I wouldn't be here without them. I thought about putting gorilla bodies on all of them, but then I thought, no, that's a terrible idea. I shouldn't do that, so I did not do it. So thank you so much to all of my mentors and over the years. And also I have an incredible network of people who I collaborate with, who I work together with on a daily basis on all of these projects. There are so many pictures. I was trying to figure out who to pull, and I could have done slide after slide after slide of people who I've collaborated with over the years. So thank you to everyone who's been part of this. I also want to say a special thank you to the Social and Behavioral Interventions Program. So I've had the privilege of being the program director for the last 8 years of SBI, and some of those gorillas, Peter Winch and Ellie Lancini, really set a tone for SBI of being a warm and connected and welcoming place, and just a place to thrive and grow. And I hope we've been able to continue that. And I love my colleagues in SBI, students over the years, all the faculty who work with us and staff. And I just want to say, I see this as also a connections and a way of sort of going global to local. Like we start local here in Baltimore, we bring people in as students in our program, and then they go out and they do amazing things in the world. And even though I may not have saved a single person from HIV, I think through those generations of students who've gone out to do this work, they are doing much better work than I ever could. So thank you to all of them. And thank you also to the school for being a really, and I say this very genuinely, a very wonderful environment to have grown as a faculty member. I really value it. And we are often, I can't tell you how often I'm like looking at the details of a grade table and trying to figure out, okay, how should I grade the epidemiological rigor of this study? All these details, right? You get sucked into those daily emails and details. And there's a lot of work-life balance and a lot of support. And I really have valued the support that I've gotten in this community and the work life over the years. I have to say, having 2 kids. So this is my daughter going to the World Health Organization when she was a baby. She would not take a bottle. She was very particular. And so I was like, okay, I need to go to WHO. If you can't take a bottle, I guess you're going to come with me. So I just want to say I've had these incredible relationships where people supported me. I told my WHO colleagues, listen, I need to bring my baby. Can you help me find a nanny? Is there someone who can watch her while I'm in the meeting? And they were able to make that happen. And similarly, there have been people throughout the years who've made that happen for me here. So thank you to all of them. A huge thanks to my family, of course, my parents who are here, my kids who are here, and my husband, Larry, who, will listen to me talk about a WHO guideline just as much as he will pick up the kids to bring them to a talk like this. So I really appreciate all of that. And with that, just a thanks to all the people who've participated in these studies. It's a community effort over the years, our research projects, the global policy development, everything, my colleagues at all these wonderful institutions who I just really value their relationships. Amazing students over the years, my family and friends, everyone who is listening, and I probably should have put half of you on these slides as well, so thank you for listening. And my daughter told me that I really needed to thank the most important person, which is Pebbles. So thank you, Pebbles, our cat. Thank you, everyone, for being here, and I really appreciate it.
And I noticed your children were glued to you and watching you, and it's so great to have you and have your family here with us.
Well,
and I just want to say, I'm sure you're very humble, and it's difficult to quantify your individual impact, but I bet you ask anybody in the field of HIV prevention, what your impact has been, and they'll all say huge. So yes, it's collective, but don't sell yourself short in terms of the impact you've had. And thank you for that. So with that, I'd love to open it up for some questions, comments for Caitlin. And if you are online, you can, you can't raise your hand because we can't see you. But yes, you can, because Becky can see you online. So raise your hand or put something in the chat. Yeah, go ahead. Oh, yes, you need this. Got to play my Vanya. Yep.
Congrats, Caitlin. This is really so great to hear about all of your work and how much you've accomplished. One of the things I like about the local stories part in qualitative research is that you really do kind of put faces and you associate emotions with the things that you've kind of collected and the stories that you hear. So is there any story that you kind of feel like that was one that stuck with you for a long while, something that maybe it didn't make it into a paper, but it was sort of something that really pulled at your heartstrings a little bit?
Ooh.
Question.
Yeah, you if you're a qualitative researcher, which you are, you read a lot of transcripts, right? And often you're sort of looking for themes. No, please. And trying to think, okay, where am I going? Am I going to theorize this in one way or the other? Do I have enough data, evidence to sort of build up a support for this? But sometimes there are just really heartbreaking stories. And there's not one that stands out, but consistently stories of poverty, consistently stories of, loss, of deaths in families, of loss due to HIV, but also other things. Consistently, I will say the fishing communities are a tough place to work. There's a lot of people who go there. There's a whole nother set of work that was done about sort of our fishing communities. Why do they have such high prevalence? Sorry, this is a distraction from your story. But, are they are people going, the initial thought was people are going to these fishing communities and getting HIV there because they're engaging in risky behavior, and there's, they're getting HIV because there's so many people living with HIV there. But some of the epidemiologic data that folks in Rakai did, that my colleagues worked on, showed that actually that's not the case. Actually, in-migrants already have HIV at much higher rates than their home communities. And so it's people leaving their home communities often because of stigma, because they can't do what they want to do in their home communities. They don't feel welcome there. And these fishing communities are a place where they feel, where they know lots of people have HIV here. And it's I don't know if I'd say welcoming, but they feel everyone is stigmatized here. Everyone has the same issue, right? And so I think there's just a lot of sad stories about how people ended up in those places. I don't know if there's one in particular, but there's unfortunately many.
Yes, go ahead.
Thank you so much for sharing your story, your work. All of this was really, really inspiring. I have a question about the part where you connected the global evidence to the local action. Do you feel like there is something like an innovation fatigue in the communities? Because you mentioned that every couple of years, a new innovation comes into the field at WHO, and that gets translated into the community. And if there is, are there any challenges with that, and how you worked your way through them? Thank you.
Actually, what that makes me think of, I don't know in the communities if there's innovation fatigue necessarily. I think they just want good services, and then whatever those end up looking like, that's what they want. For providers, though, actually, one of our most recent papers was looking at new injectable forms of HIV treatment, right? And these are around, they're available in the US, they're starting to be rolled out in places like Uganda, but they're not widely available. And so we were asking health providers like, okay, this might be coming, what do you think? There's sort of storage requirements, how would this affect, your process, and how would it fit in, and what do we need to do to think about being prepared for this new innovation? And one of the interesting themes that came out of those providers was they were like, well, listen, we are constantly, every couple of years, we have to do new things. And so we'll be able to handle this too. I'm pretty sure, yeah, there might be some issues, but we'll be able to handle it. So it was actually one of the themes we brought out was they're willing and used to doing this, which is, I guess, good.
And Caitlin, Ted Nieris has a question online, and maybe Ted, if you want to unmute yourself, you could ask the question.
Thank you. Professor Kennedy, thank you so much for this talk. The question is related to the previous question just now. One of the challenges that we face in the HIV response is that many times important public health innovations remain out of reach to the people who need them most. They remain inaccessible, they increase inequity. In your view, in your experience, academic as well as in the WHO space, how do we ensure, or what are some of the tips for ensuring that as we do our work, that we improve rather than reduce equity? Thank you.
Ooh.
Easy question.
Thanks, Ted. Yeah, easy question. It's nice to see all these names from different parts of my world. That's a tough one. And I think you're absolutely right. There's a lot of interest in sort of the new shiny thing. And I think some of these injectable, both prevention and treatment methods are that. And it's tough because on the one hand, we haven't achieved what we want to achieve with existing approaches. And so it's tempting to look at these new approaches and say, would they solve some of the problems that we have with existing approaches? People don't like to take pills, and they forget to take their pills, and it's hard to remember it. And so would an injection every 2 months or every 6 months, would that be a lot better? Probably for a lot of people it would be. And so that's what we're looking at. And there are still people left behind. And I think it's really important to both continually look at those people left behind and sort of why they're left behind, because with every new innovation, there's different reasons for why people are left behind, right? And so that's, again, some of the work we were doing with these treatment trajectories was, well, 20 years ago, people weren't getting treatment for very different reasons, and they're not getting treatment now. And so to continually not just think like, oh, we already know why people don't do treatment, but to think, no, now with these new innovations, what's being left behind, I think is really important. That's not a full answer to your question. WHO looks at equity in all their guidelines. And I will say, having been in so many processes where there's a guided, structured discussion about how do we consider equity, it's so hard because, WHO, for example, they don't have the ability to tell governments what to do. They could just make these sort of global recommendations with some comments about, hey, you might want to think about equity as you're rolling it out. But in different communities, that equity looks so different. Like in fishing communities in South Central Uganda, you know, the social dynamics there and why people are at risk or why people aren't accessing services are completely different from other settings. So it does need to be a locally tailored response, I think. And that's hard to do systematically other than to keep banging the drum. And I think the HIV community has done a pretty good job, relatively speaking, of continually banging the drum that equity matters, human rights matter. We need to look at who's being left behind and keep doing that again and again. That's the best I can do, Ted.
Well done. Well done. Well, if there aren't any other questions, I think we have an opportunity again to thank Caitlin for an incredible lecture, but also, and more importantly, for all that she has done and all she continues to do for public health and for the school. And with that, I invite you all to join us at the newly invigorated Wall of Wonder for a reception. Thank you all very, very much for coming.